Hey guys, welcome back to my channel, The ENT Resident. Today, our topic of discussion is going to be about papillary carcinoma of thyroid. You can also purchase my notes now. I have added links in the description. Okay, so before we start discussing on papillary carcinoma, I just wanted to tell you first that thyroid cancer, when it is differentiated, it consists of two types. One is papillary carcinoma and one is follicular carcinoma. So both these carcinoma take its origin from the follicular cells of thyroid. So in today's discussion, I'll be discussing about papillary carcinoma, and in my next class, I'll be talking about follicular carcinoma of thyroid. So let's get started with papillary carcinoma. So papillary carcinoma is the most common thyroid cancer amongst all of the varieties. About 60 to 80% of thyroid tumors are papillary carcinoma. This is common in the age group of third to fourth decade, and it has a more female preponderance, about a ratio of 3:1. However, this gender bias usually is less pronounced when the patient is above the age of 50 years. Another important MCQ point over here is that thyroid papillary carcinoma is the commonest pediatric thyroid malignancy. And this is a carcinoma which has excellent prognosis, especially if it has happened in a younger patient. So, any patient who gets a papillary carcinoma has probably gotten the best prognosis out of all the other thyroid cancers. And as I mentioned, papillary carcinoma takes its origin from the follicular cells of the thyroid, and gets its name from this typical feature that it has, that it consists of a fibrovascular stalk with cancerous follicular cells forming a papilla, hence the name papillary carcinoma. So these are some very important points over here that each one of these points can come off as an MCQ question in your entrance exams. Now let's discuss what are the risk factors to developing papillary carcinoma. First is exposure to ionizing radiation. So whenever there is a history of exposure to ionizing radiation, it is important to think of this differential diagnosis. So the low dose radiation to the head and neck region in the previous years is a risk factor. Second is familial conditions. So, in about 5 to 10% cases of papillary thyroid carcinoma, it has been seen to have a family history of thyroid cancer. Now, there are certain syndromes associated with this. The first one is Cowden syndrome. Although even the Cowden syndrome is associated with papillary carcinoma, compared to this, it is more often seen to be associated with follicular carcinoma of the thyroid. Papillary carcinoma has more rarer occurrence in Cowden syndrome. So, in Cowden syndrome, you see multiple hematomas, breast tumors, skin tags, and thyroid cancer. Second is Gardner's syndrome, where we see familial colonic polyposis along with thyroid cancer. This is our syndromes associated with papillary carcinoma. Third is it has been seen that papillary carcinoma is seen more commonly in areas where there is adequate iodine intake, whereas follicular carcinoma has been seen to be more happening in places where there is iodine insufficiency. And last, another very important MCQ question over here is what are the associated mutations with papillary carcinoma? So, the most common ones are BRAF V600E mutation, and second is RET PTC translocation. So, these are a lot of important MCQ points right over here that I have discussed so far. Now, let's move on to what are the clinical features that we'll see in such a case. So, more often than not, it can be a presentation of an asymptomatic mass in the thyroid region. It can present as a firm, non capsulated thyroid nodule. Now, papillary carcinoma, another very important thing to remember is this tumor is more often to be multicentric in origin in about 80% cases. So, it can actually end up involving both the lobes of the thyroid. Other than this, Next, talking about lymph node spread, lymph node metastasis is actually very common in papillary carcinoma, seen in about 1/3 cases. So, this is the most common metastasis that you will be seeing in case of papillary carcinoma. Now, depending on local invasion, the mass that is appearing in the thyroid, it can end up producing symptoms of local invasion. If it invades the strap muscles or if it invades the trachea, it can lead to dyspnea. If it invades esophagus, it can lead to dysphagia. If it involves any laryngeal nerves, it can lead to hoarseness of the voice. So you can have pressure symptoms or infiltration symptoms because of these structures getting involved. Next, moving on to distant metastasis. Distant metastasis is not as common in papillary carcinoma, and if it does happen, in that case, the most common site is pulmonary metastasis. Other than pulmonary metastasis, the next common site would be bone metastasis. And distant metastasis is seen more commonly in older people and those who have extrathyroidal spread. Another important thing to remember here is in areas where there is adequate dietary intake of iodine, it presents as a solitary nodule of thyroid. However, in regions which have iodine insufficiency, in those areas, multinodular goiter is the more common presentation. In 50% children and 20% adults, lymph nodes are seen to be palpable at the time of diagnosis. So, these are all the clinical features that a papillary carcinoma of thyroid will present with. Next is, let's talk about very important portion over here is the histology of the papillary thyroid cancer. So first of all, let's talk about the gross features on macroscopy. So cut surface will show a solid granular appearance with irregular outline, and it will have either a serous or granular gritty texture, often with multiloculated cystic change and colloid contents. This is the gross appearance of papillary carcinoma. Next, let's talk about the microscopic appearance. Now, here there's a lot of MCQ questions and even questions that can be image based that you need to know about. So, first, let's start with what is the principal defining feature over here. So, the principal defining feature are all the nuclear morphology that we will be seeing. So, first of all, coming from the name of the cancer, which is papillary carcinoma, so this is characterized by the presence of numerous papillae, which are basically finger-like projections with a fibrovascular core. Second, there will be focal nucleomegaly, nuclear crowding and nuclear overlap, which is often described as a basket of eggs. If you see in the image over here, you can see that. Third is a very, very important feature, which is a very important MCQ question, is the presence of Orphan Annie eye nuclei. Now, what is Orphan Annie eye nuclei? So, first let me describe it. So, this is homogenization of the karyoplasm, giving a very ground glass nuclei appearance with margination of chromatin, and this ends up resembling, if you know this very famous cartoon and you can see the image over here, the empty looking pupil-less eyes of Orphan Annie. So this is characteristic of papillary carcinoma of thyroid. However, it is important to remember that this is not pathognomonic of this disease. It is not specific to this disease. Orphan Annie nuclei is seen in a lot of other conditions as well. So, if you had to describe simply what is Orphan Annie eye nuclei, you would say that there is abundant pale cytoplasm with typical optically clear nuclei. This image over here, you can see all these nuclei over here that they look like the empty eyes of Orphan Annie. So this is a very important feature that we see in the histology of papillary carcinoma. Next is we see something which is known as longitudinal nuclear grooves, which is also called as coffee bean nuclei. If you see in this image over here, you will be seeing that these are the longitudinal nuclear grooves, and this, as you see this image, this looks like as if it is a coffee bean. Fifth is there is intranuclei pseudo-inclusions, which are cytoplasmic invaginations into the nucleus. Another very important MCQ question and a feature of histology here is the presence of Psammoma bodies. If you see in the first image over here, these are Psammoma bodies. Now, what are Psammoma bodies? These are these microscopic round, lamellated calcification, which appear as concentric onion skin like calcified spirules. And Psammoma bodies are seen in about 50% cases. Again, Psammoma bodies presence is not pathognomonic of papillary thyroid cancer because you definitely see Psammoma bodies in a lot of other conditions as well. So, Psammoma bodies, coffee bean nuclei, Orphan Annie nuclei, these are all distinct features that you will be seeing in a papillary carcinoma of thyroid. Now, according to histology, what we just discussed is the normal one. Now, there are some histological variants of papillary thyroid carcinoma. Now, here is the long list of variants that you can see over here. However, I'll discuss only a few of them which are more commonly seen. So, the first one is the follicular variant. In the follicular variant, you see more of Psammoma bodies. Second is a papillary microcarcinoma. Now, what is a microcarcinoma? This is when the tumor is less than equal to 1 centimeter diameter in size. Papillary microcarcinoma is said to have excellent prognosis with almost no mortality. So, this is very, very important to remember. Third type is a diffuse sclerosing variant. Now, this variant has the worst prognosis. Why? Because of its widespread lymph node metastasis. And the most common site of metastasis in this case is lungs. And in this variant, you see a lot of Psammoma bodies and squamous metaplasia. And a differential diagnosis of this condition is Hashimoto's thyroiditis. Next is the tall cell variant. Now, a feature of the tall cell variant is that they have abundant eosinophilic cytoplasm, lymphocytic infiltrate, and this variant also has a bad prognosis. Last of all is the columnar variant. This variant basically has tall cells with nuclear stratification. So, this is all regarding the histology of papillary thyroid cancer. Next, let's talk about the investigations. Now, I have already discussed about investigations a lot more in detail in my last video on thyroid cancer, but here we'll just touch on it a little bit. So, first of all, we perform a fine needle aspiration cytology that helps you with the diagnosis. Second, when you do an ultrasound of the thyroid and neck, you look for not only lesions of thyroid, you look for lesions, not only what you have examined in the patient, you should look for multiple other lesions which are not palpable, because this particular disease is multifocal. So it can actually have multiple sites of origin inside the thyroid gland. Second, we'll check for lymph node metastasis. And there are four cardinal features that you have to remember, that if you see these features in the thyroid, it confirms the presence of papillary carcinoma of the thyroid. Now, these features are that the mass in the nodule will be solid and hypoechoic, have ill-defined margins, presence of microcalcifications, and a taller than wide shape. So these four features are very, very important in ultrasound of the thyroid in papillary carcinoma. Next, when you do a thyroid function test, it will reveal hyperthyroidism, though most patients can also be euthyroid. This helps you in setting up baseline for the patient before you go for a surgery. Next, if you perform X-ray chest, if there has been pulmonary metastasis, you may see that. And then you'll also perform a CT scan or an MRI to see the extent of the disease or check for retrosternal extension. Now, it's very important to remember here that if you are using iodinated contrast for the CT scan, now this can have its own restrictions on the treatment plan. Now, if your treatment plan involves total thyroidectomy followed by post-operative radioiodine ablation, then you have to be aware that you cannot use it immediately. So, for 2 months, within 2 months of the scan, you cannot be using radioiodine ablation because of the high concentration of iodinated contrast taken up by the thyroid. This will diminish the effectiveness of the radioiodine. So you'll have to wait for 2 months to be able to do that. So these are the investigations for papillary thyroid carcinoma. Next, let's talk about the treatment. Now, the mainstay of treatment over here is to perform thyroidectomy. However, what thyroidectomy to perform is a question. Now, in recent times, there has been more shift towards performing a conservative surgery rather than a radical one. So, if the tumor is less than 1 centimeter or if it is unifocal, or if it does not have any extrathyroidal extension, or there is no lymph node metastasis, in these cases, you may think of performing a hemithyroidectomy. Some indications of total thyroidectomy in the papillary thyroid carcinoma are tumors which is more than 4 centimeter in size, multifocal disease, bilateral disease, extrathyroidal spread, any confirmed nodal or distant metastasis, old age of more than 55 years old, a history of radiation exposure, a history where there is a familial differentiated thyroid cancer, or the presence of adverse site histopathological features. In all of these cases, you should definitely go for total thyroidectomy. Next, coming on to the part of neck dissection. Now, what is the importance over here? When will you perform a neck dissection? So, it has been seen that there is no benefit of lateral neck dissection in patients who do not have any overt lateral neck disease. So, there will be only indications of central neck dissection. Now, when will you perform central neck dissection? When the tumor is more than 4 centimeter in size, when there is presence of extrathyroidal extension, in cases of aggressive histology, and in cases where you have clinical or radiological positive nodes. So, these are the indications for performing a central neck dissection in a case of papillary thyroid cancer. Next treatment option is a thyroid hormone suppression therapy. Now, this is usually done after the surgery is completed, where you do a TSH suppression with either thyroxine T4, with the dose is 2 mcg per kg, or with liothyronine until the histopathology reports are available. So, this is thyroid hormone suppression therapy. Next mode of treatment is radioiodine ablation. Now, for radioiodine to be effective as an ablative agent, it is important to know that you need a total thyroidectomy. So, in patients who have had hemithyroidectomy, in these cases, if you are thinking of giving radioiodine ablation, in that case, you will definitely have to perform a completion thyroidectomy and prior to giving this treatment. So we give I-131 about 6 to 8 weeks post surgery. Now, what would be the indications of you using radioiodine ablation in patients of papillary thyroid carcinoma? Again, these are all features that we just discussed for total thyroidectomy, like tumors which are more than 4 centimeter, or if there is gross extrathyroidal spread, or presence of distant metastasis, or if tumors are between 1 to 4 centimeter but they have some poor prognostic features like aggressive histology or extracapsular invasion, or there is multiple lymph node involvement. These are all the indications where you will perform a radioiodine ablation postoperatively. Last option here is an external beam radiotherapy. The indications are very less over here. It's only done when there is gross evidence of local tumor invasion at surgery, or in case of residual or recurrent tumors, which is non radioiodine avid. IMRT is the method of choice over here. Now, what is IMRT? It is intensity modulated radiotherapy. So, these are all the treatment options we have. Now, how do we assess the outcome of the treatment that we have given? So, there are three ways to do that. First of all, is to perform a post radioiodine scan. This is usually done between 2 to 10 days after ablation. This will help you assess the uptake of radioiodine in the thyroid bed as well as the extent of residual and metastatic disease. So, this is one mode of seeing what the treatment outcome is. Second, the most sensitive one for recurrent or residual disease is a stimulated thyroglobulin measurement. So, how do you stimulate it? We inject recombinant TSH 9 to 12 months after surgery with the measurement of the thyroglobulin and autoantibodies following this. If stimulated thyroglobulin is less than 0.5 mcg per liter, then it is disease free. But if it is more than 2 mcg per liter, it is highly predictive of persistent disease. Now, if you were to check for unstimulated thyroglobulin and you find that it is less than zero point 0.1 mcg per liter in absence of thyroglobulin antibodies and a negative ultrasound, this also has a very high negative predictive value that the patient is disease free. Last option over here is to perform a CT scan. Now, this is done only if the measurement of serum thyroglobulin has been unreliable, or when you post radiation post radioiodine ablation scan has shown uptake beyond the neck. Only in that case we perform a CT scan. Now let's talk about how will we follow up these patients. Now there are three types of response a patient can have. Now three groups. The first group is patients who have had an excellent response. Now what is the criteria for excellent response? These are the patients who have had surgery and radioiodine ablation. Their stimulated thyroglobulin is less than 1 mcg per liter and they have a negative ultrasound. In these cases, we'll follow up with an annual thyroglobulin assessment, and the TSH is to be maintained between zero point 0.3 to 2 milliunits per liter. And it is very important to remember here is if there is appearance of thyroglobulin and autoantibodies in a case where there was no presence of thyroglobulin autoantibodies previously, or there has been a gradual rise, this may indicate the evidence of a recurrent disease. So this is what you'll do in follow-up of patients who have had an excellent response. Next is patients who have had an incomplete response. Now, what is the criteria for this? This is when the stimulated thyroglobulin is more than 10 mcg per liter, or there is a rise in thyroglobulin concentration. Now, these cases they may also have a recurrence in the neck ultrasound. So, if you in these cases you perform an ultrasound of the neck, if that is normal, in that case we perform a CT scan or the MRI. If that is negative, we'll perform a PET scan, and even if that is negative, we'll perform a radioiodine scan, which is I-131. Now, after this, if we see that there is evidence of surgically resectable disease, we'll go for surgery. But if it is not possible, in that case, we'll perform a radioiodine therapy with a TSH suppression indefinitely. This is how we manage patients who have had an unfavorable response. Last group is the patient who have had indeterminate or equivocal response. What does that mean? These cases have a stimulated thyroglobulin of 1 to 10 mcg per liter with non-specific changes on neck ultrasound. So these cases would be follow up with the review with serial thyroglobulin measurement and ultrasound to detect any recurrence, and TSH has to be maintained between 0.1 to 0.5 for at least 5 to 10 years. So that's all about treatment. What are the treatment options? How would you assess the treatment outcome and how would you follow up the patients? Last part is the prognosis of papillary thyroid cancer. Now, the 10-year survival rate is actually very good. If it is limited to the thyroid, then it is 90%. If it is gone beyond the thyroid, then it is 60%. What are some poor prognostic factors? Clinical factors would be an older age group like more than 55 years old, male, large size of tumor meaning more than 4 centimeter, extrathyroidal extension, and nodal metastasis. And some pathological prognostic factors are having vascular invasion, aneuploidy, having tall cell variant or a diffuse sclerosing variant, a follicular variant, or a columnar variant. So, this is all about papillary thyroid cancer. If you have any doubts about this, please note them down in the comment section and I'll get back to you.